Hi, I'm Dr. Pajari, host of the Prognosis, which is a palliative podcast. And today we will be talking about what is hospice, questions pertaining to hospice. My guest today is Evelyn Perrez Rivera, who's back for more questions. So welcome and enjoy. This question is, once you are on hospice, admitted to hospice, what does it mean to stay on hospice? What is that experience of being on hospice? So the admission, a lot of people have questions about how the admission will go. Another big area of questions are, they start to ask many questions about, will this happen, or when will I see this person, or what will, they're not understanding. So this is to provide clarification on what the experience of being on hospice is after you've been admitted to the program of hospice.
So after the patient has been admitted to the hospice program, that patient and that family gets assigned a case manager. And that case manager is a registered nurse. And the whole team kind of just comes together. I often tell patients that those first 5 days is a circus because everybody is calling from the team. The chaplain is calling, the social worker is calling, the CNA. At the admission, it was determined that the patient is going to need the CNA services 3 times a week. So trying to start implementing all those things along with anything else that we needed that it was not there during the admission. Moving forward with that, after the 5 days, that case manager, which is the registered nurse, will continue to see the patients as long as, or as many times as needed, not as long as they need it, because the nurse cannot be removed from that care. Families and patients can decline the CNA, can decline chaplain, can decline social work. But the reason why they came on hospice is because there is a medical necessity. So then there has to be an oversight by a registered nurse. At that time, as the time continue moving forward, the nurse will see that patient, whether it's 1 time a week, 1 time every 2 weeks. And then for the first,
it can be quite frequent too.
And it can, exactly. That is driven by the patient's condition and the patient's condition only. Toward the end of life, it is customary that you see the patient every single day because we know that the time is approaching. But in order to stay on hospice, Medicare has put some rules that if for the first time that you come on hospice services, there is your first 90 days. That is 3 months of hospice. And during that time, then we will see a decline. In many times, it's very little decline, depending on how is the patient in their condition. And as the 90 days approaches, I'm going to back it up for just a minute. Every 14 days, there is a team meeting. That team meeting consists of the medical director, the nurses. CNAs can be present there, although not required, but in many hospices, they are part of that IDG or IDT. IDG is interdisciplinary disciplines, or IDT, interdisciplinary team. And that patient's condition from the medical and social and spiritual gets discussed about that. How those conversations go? Well, they might need resources from social work. There might be some unfinished business that the chaplain can help for that patient to come to a better place emotionally. And of course, the medical aspect of it, as we record the decline, then that patient is going to need a lot more. When the 90 days come, or shortly before after that, within 2 to 4 weeks before those 90 days, that patient is already being reviewed for another 90 days. And to stay on service, there has to be a decline, which usually we see that very commonly.
Yeah, so that actually brings us to that concept of 6 months that we were talking about, that Medicare kind of says, okay, within this time, we're expecting that this patient will pass away. Now, that doesn't mean a hard and fast. It has to be 6 months. Another thing to mention, so we talked about once you've been admitted, and you've gotten equipment and medications are put in the home, the emergency kit is put in the home, your care team has introduced themselves, called you, the nurse, you know who is assigned to see you, and you kind of gauge how often or frequent that's going to be. If you have social work needs or insurance needs, some assistance needs, so the social worker can put things in place or start to work on that, and then the chaplain is there too. And all the while we're providing medical oversight. And then absolutely, like you said, about IDT or IDG, same term really for the meeting that we have every 14 days. We're really reviewing things carefully to make sure each patient continues to justify themselves being on service. In addition to that, then we also have levels of care that can be provided within the hospice benefit. Most, or not most, we have a lot of patients that come on with routine care. That's one level that can be provided, which is just routine care, seeing the patient in their home. There is the option also for GIP, which is an inpatient option. If there is an inpatient hospice, that's a higher level of care for acute management of symptoms. And then we also have continuous care, and we also have respite care. Respite giving the caregivers a break up to 5 days for the patient in a facility, generally a nursing home, where they can provide support. And then continuous care, which gets provided in the home if the patient requires continuous management for a period of time of an acute symptom. I will say something that we do well in this era of not having as many inpatient units to go to as before, we are quite good at managing acuity in the home, managing acute pain crises. I'm willing to put in that infusion or really adjust the medication regimen, or having a respiratory crisis, or having these acute issues. So we're quite good at doing that. Yeah. But did you want to speak to anything on the levels of care?
I do. I wanted to kind of just also bring back to the people that are watching that sometimes not every hospice is the same type of hospice. And going in with the expectations that they will put drips or that they will do a little more aggressive, that is individual to the hospice company. We know that depending on where you are, in which company you work for, is different. We do it well. I was thinking about GIP, where we can almost pull a very intense acute crisis at the house and be able to manage it through our nurses, because you put things in place.
Yeah, we have had GIP level management, and we can do it. It can be done in the home. I mean, maybe that's an incredible message to offer too, but GIP meaning almost like a hospital form of acute management in the hospice setting. That can be done in the home setting. It requires, a lot of good nursing. It requires a good CNA services. It requires very good medical oversight.
That is correct.
So, but it can be done. And I agree with you. The other thing that other hospices, may or may not do is, we've talked about this, having communication routinely with the family. All levels of communication. The nurse, of course, should be communicating well with the family, social worker and chaplain, but I also believe the medical director should be communicating with the family too.
And that's another thing that we do very right, or do an excellent job at it, and that is having conference calls with the families and with the patients, understanding where they at in the continuum, helping them understand what they are seeing, providing prognosis.
Very much, yeah. So I think that gives a good explanation. We talked about, onboarding a patient, bringing someone on service with hospice, and then what happens afterwards. All of the care that gets put in place and making sure that that patient continues to qualify, really per Medicare guidelines most of the time, but continues to qualify, and over those that 6-month period. Then after that, we continue to monitor the patient, but we are having routine meetings to make sure we're discussing the patient. And during that time, there can be different levels of care. And as we said, we can really manage quite a bit. If you're very dedicated service, you can manage quite a bit of that in the home. I mean, I would say virtually all of it, actually.
Absolutely.
Which is amazing. I think personally you could bring hospice to the home 100%. You just have to have that in place. But so.
Absolutely.
All right. Thank you.